Good afternoon. This is Kristen Hall of Fusion 5. Thank you so much for joining us today for the overview of the BPCI Advanced 101 presentation. This afternoon we have Jerry Rupp, our Chief Integration Officer, who will be walking you through the BPCI Advanced presentation.
Hello everybody, and thank you for joining. I'll run through this relatively quickly, I hope. I think I'll cover some territory in here that will hopefully explain the general principles of BPCI Advanced. There will be upcoming webinars that will dive more deeply into some of the aspects, but we just wanted to be able to present BPCI as an overview to start with. So here's the agenda for what we're going to try to cover: a little bit on what is BPCI Advanced, a little bit on the creation of the episodes, a little bit on what the financial arrangements can be, or the financial side of BPCI, and some of the practices in terms of how do you become successful in BPCI, and a lot of that hinges on care redesign and an overview of that process, and some of the compliance items that crop up in terms of doing BPCI Advanced, the legal aspects, compliance to the legal waivers that exist, and other waivers that are part of the program. So we'll touch on each one of these. Again, certain aspects of these will be topics of future presentations, which will dive more deeply. I'm just here to try to introduce these as a general concept to you. So what is BPCI Advanced? Well, first off, it's advanced. Therefore, it is based on a predecessor, which is now currently termed BPCI Classic. They added the term Classic actually while the original program was running. BPCI stands for Bundled Payments for Care Improvement. And so what this is a bundled payment program through Medicare for Medicare A and B patients only, that while some believe this was meant to test the capacity for bundle of payments to be a payment model, that is not exactly true. Bundled payments as a payment model have been proven to CMS back in what was called the ACE demonstration project, which was almost 2 decades ago. What BPCI Classic and now the newest iteration Advanced are meant to do is determine scope of what can be bundled in terms of what types of clinical episodes, which ones work the best, and scalability, scaling across the country, scaling across all different types of providers. And that is the general tenet for what BPCI Advanced is. So why does CMS support bundled payments in the first place? The first thing to know is, what does CMS care most about? There are 2 things that they care about, and virtually nothing else. They care about the Medicare trust, because without the trust, we don't have to worry about anything that is Medicare, and mostly what CMS does. So they're looking to preserve the trust and the dollars in that trust for as long as possible. And for those of you that are on the phone, I'm sure that you would like that to happen as well, because no matter what happens, all of us will reach the age that Medicare is a primary health care coverage, and we would prefer it to be around as well. The second thing they care about is the Medicare beneficiary. They want to make sure that the beneficiaries are taken care of appropriately for health care, and that the trust is around to support the health care needs that they have. After that, pretty limited on what they absolutely care about. And so why do they support bundled payments? Because this is a methodology to improve care for the Medicare beneficiaries, one of the items they care about, and to do so ideally at a lower cost. So improving care, better patient outcomes, better patient satisfaction, lower cost. We've hit the 2 elements that they do in fact care about. Okay. This is done through a variety of things that you can see on the slide in front of you. Care redesign efforts. This encourages you to re-engineer your care. Components of data analytics are important. In order to determine how to re-engineer care, you need to understand what the data tells you historically, what you can do moving forward, how you can provide value to care, improve quality, but lower costs at the same time. Identify where those overutilization and overcost services were taking place historically, and historically depends on on time period. Anything that happened before is history, and what you can do with those in the future. It puts in financial accountability. This is a risk-bearing model. There is a two-sided risk. You can have gains if you have upside potential, which we'll see later when we get to the payment models about how that works. But there's also downside risk, that if you go over target, money is owed back to Medicare. And therefore, there is accountability in the financial aspects of the program. And so the ultimate goal is to reduce spending, but not at the compromise of care. Care has to be at least the same, if not, in fact, better. To accomplish these tasks, you're looking for provider engagement, and provider means a whole lot of things. That is your primary physician provider in terms of most of these are specialists that are in episodic care, not always, but a majority of them are specialists. That provider, the physician, their clinical staff, that practice, as well as the hospital, where most of these procedures are done, or the hospital outpatient setting where some of these procedures are done. It could be post-acute care providers that are part of the provider engagement. We're looking for an association of all the providers along the continuum of care to create that environment that stimulates coordination among those post-acute care and acute care providers, and the main quarterback, which is the main physician for whatever procedure was being done. If this is an orthopedic procedure, it is the orthopod. If we're talking about a cardiac procedure, it's the cardiologist or the cardiac interventionist, whatever it may be. We also want to include the patient themselves, because they are at the center of this no matter what. They are centered here, and we're looking to do patient-centered care. This is how we start to really work on how do you improve care and make the experience better for the patient. Make sure that they're at the center and you're doing what they need, not what historically was done because this is what we've always done. But also to include their family members, their caregivers, whatever that support mechanism that they had. Because as you involve everybody in the decision-making process and along the continuum of care, you have an increased likelihood for better outcomes. So bundles themselves, which BPCI is, remember, the B stands for bundled payments, are a popular method along the continuum of changes from fee-for-service. And so this is a graphical representation of where things were and the changes that are underway, where you have a change from fee-for-service to pay-for-value. And you notice that as you increase in value or quality along the x-axis or the bottom axis from low to high, there's a corresponding increase on the y-axis for financial risk from low to high. So as we move from fee-for-service up the scale, we are increasing risk, but as you well know from playing the stock market, sometimes those with greater risk can have greater rewards. And so as we move across this continuum, you'll see a change from fee-for-service to shared savings methodologies. They do still exist. Fee-for-service certainly currently exists. And as you'll understand, BPCI, whether classic or advanced itself, is a fee-for-service model. It's a bundle built on top of a fee-for-service model, which is why it's called retrospective. It means we're going to look back at the fee-for-service rates over time for any given episode of care, or a patient, if you want to consider it, as they move forward, and determine whether the total cost for that patient for the complete episode of care was greater than, equal to, or less than a target which was generated from historical performance. If it's greater than the target, dollars are owed back to CMS based on fee-for-service payments. If it is less than target, then CMS will pay out the target, and excess dollars will be received by the providers who perform the service, or who own the bundle, if you will, or who are engaged in the bundle payment program. You can see where bundles currently sit. As we progress through time, we can see that population health is a part of this. You can consider this capitation. I actually like that better. There's a synergy that can exist between population health, or what is ACOs, and bundles, which needs to be explored, and yet a different payment model constructed that can work best for both of them. So a little bit of history and structure of bundled payments. I covered the territory that BPCI Advanced was generated by BPCI Classic, developed by the Center for Medicare and Medicaid Innovation, which is termed CMMI. Those of you that are familiar with CMS know that they love acronyms, usually three-letter acronyms, but not always. And so there are a lot of them. I'm going to try to avoid as many acronyms as I can, but it's almost impossible to do that on a routine basis. And so what we're looking at here in this graphic representation in the middle is a typical episode of care. It starts with the anchor hospitalization. The anchor event is the admission to a hospital. Now, the actual event for the episode of care starts 72 hours before that, and any cost incurred in that window. For most of the episodes that are part of BPCI, there is little that happens during that period. If costs happen well before that, like clearances for surgery, blood tests, whatever it may be, they usually happen outside of that window. They're not included within the bundle period. The entire hospital stay, regardless of what that duration is, for orthopedic cases, it is often in the kind of 2 to 5 day window, depending on what type of episode we're talking about. For other episodes, this may be a longer time. Whatever that geometric or arithmetic mean is, that is covered in here, as well as the period 90 days post-discharge, which includes all of the post-acute care providers, SNF, skilled nursing facility, inpatient rehab, or acute care rehab. It will be LTACs, which is long-term care hospitalization, and any physical therapy, occupational therapy, anything that happens downstream, home health, and will include readmissions, as you'll come to see. There are very few exclusions to this program. There are certain readmission exclusions that do not exclude the patient, but rather exclude the cost of the readmission. They are highly limited. CMS Medicare is based on everybody's in all-inclusive. It's kind of like going to the ballpark and you bought the all-inclusive tickets. You get to see the game, you get to have food, and you get to have drinks, and it's all built into one price. CMS believes that in that particular principle, and so virtually everything is in, very little is out. We will cover downstream a little bit of some of the out. Again, this is Medicare fee-for-service A and B. It is not Medicare Advantage plans. It is not VA. It is Medicare Railroad. It is not Medicare cost programs in which Part A is billed to Medicare, but Part B is billed to an HMO. Those would be excluded. So if we look at the payment model on a glass, and remember that this was designed from its predecessors, and other demonstration projects. BPCI Advanced, one of the differences, and one of the several differences between this and Classic, is this is considered an advanced alternate payment model. For those that are familiar with the MACRA legislation and the reporting for MIPS, and what most providers call MACRA, which is really qualified provider or qualified participant designation, there is the ability to change your reporting requirements from MIPS to a more simple reporting mechanism based on being in an advanced APM and gaining the percentage of upside payment on your fee schedule associated with being a QP or obtaining QP status, as opposed to doing MIPS reporting, which is an annual reporting method in which you can either have an upswing in payments or, in fact, a downswing in payments, depending on how you perform on your MIPS measures. Okay? Payments are done, typical fee-for-service. Everybody bills fee-for-service just the way they did last year. There are no differences to that. The goal here is to manage the patient-to-patient need so that you can address and eliminate, if at all possible, unnecessary costs and overutilization of services, to manage the patient to the services that they need. And that will lower your cost relative to target. And we're going to talk about the generation of target in a little bit. Participants, we'll also talk about a little bit later, physician groups, hospitals, and something called the convener, and I'll describe conveners in a little bit downstream from here. Accountability, there is upside and downside financial risk versus target. And like every CMS-generated program, there are quality metrics. Those outcome metrics need to be performed usually against some threshold, and the ability to have financial gains or even minimize losses is based on those thresholds. The program itself is a 5-year program. It started on October 1st of 2018. We're in a time right now in 19 where there's a second application process. This was a planned event for what we would call the second cohort of applicants. We're doing that in 19 for a start of January 1st, 2020. This will be the last opportunity for any new participants, new episode initiators, a term we'll discuss in a little bit, to engage in this program moving forward. The program is 5 years. It ends at the end of 2023. Okay, so who can participate? There are what are called convener participants or non-convener participants. Okay, what is a convener participant? We're going to discuss a little bit later and define what each one of these are. But the conveners can be physician group practices, they can be hospitals, they can be hospital IDNs, they can be an independent third party like Fusion 5 is. Episode initiators are the entities that actually initiate the episodes, and we'll discuss that in a little bit. Again, they can be physician group practices or hospitals. Those are the only two entities that can initiate episodes. They have to be Medicare providers. Okay. Talk a little bit about exclusion criteria. Who is actually excluded in here? And this is a patient exclusion criteria. So I said before that CMS likes inclusion across the board. So virtually think everybody is included. All patients with a DRG bill. It does not matter what their comorbid history is at all. Excluded in terms of participating or patients that are in the various areas, or if you're in a CJR market. CJR is the Comprehensive Care for Joint Replacement Program. That is a mandatory, started as a mandatory program several years ago. It now is split between 34 mandatory markets based on MSA. And the opportunity for 33 markets that used to be mandatory went voluntary. The hospitals within that could have chosen to remain engaged in CJR or not. Currently, there's a mix of hospitals that participate. This is a hospital-only program. So all episodes start at the hospital. That program is running and will continue to run through the end of 2020. There are certain exclusion criteria for BPCI that is extremely limited. The main exclusion is based on patients that have bona fide and properly recorded end-stage renal disease, or ESRD. There are certain other patients that are excluded from BPCI because of an association with other programs, generally ACOs. But one of them is ESRD organizations. There are a couple of those, but again, ESRD patients with a clinical designation of ESRD are excluded anyway. The ACOs that exclude beneficiaries from BPCI Advanced are those that are aligned with next-gen ACOs. That is a waning program that will terminate, I believe, sometime in 2020. MSSP, which is the Medicare Shared Savings Program, the Track 3 ACOs. There are tracks 1, 1+, 2, and 3. They differ from one another in a variety of degrees. Only the track 3 ACOs take precedence over BPCI Advanced. The Vermont ACO, and what I'm going to put down is enhanced ACOs. This is part of a new designation of ACOs called Pathways to Success. They are eliminating the MSSP designation for ACOs in tracks 1 through 3 in favor of a new designation of basic, which is roughly what was tracks 1, 1+, and 2, and enhanced, which is roughly what was track 3. I put a red asterisk next to this because the actual implication of who may take precedence over BPCI or not has yet to be determined for calendar year 2020 and forward. So let's define those three types of participants that we've talked about. A convener participant, what is a convener? A convener is somebody who brings together a variety of other downstream episode initiators. So Fusion 5 is a convener, and we bring together other physician group practices in orthopedics and cardiac, in gastrointestinal, liver, if you will, services, or hospitals as well. And so for those of you that know us well, Fusion 5 has many physician group practices or PGPs and a selection of hospitals, ACHs, or hospital systems that are part of our portfolio of episode initiators or clients. You can be a non-convener participant in which you yourself are the episode initiator. The difference between the two is a convener participant facilitates the coordination among all of its downstream episode initiators. And that convener is the one that ultimately bears risk, downside risk, to CMS. But they can apportion some of that financial risk to downstream episode initiators. Non-convener participants do not have other downstream episode initiators, and they will bear financial risk only for themselves. An episode initiator can either participate as with a convener or as a non-convener participant. They are the ones that actually trigger the episodes. They are usually the providers, the physician group practices that have physicians that treat those patients and are doing the episodes clinically, or the hospital that is the location in which those episodes are occurring. And they may be a risk-bearing entity or not, depending on whether they have engaged with the program with a convener or as a non-convener participant. Who can't participate, or who, more well put, may be, who cannot trigger an episode of care? This is important to understand because as we think about looking at data, you want to be able to filter these out. So critical access hospitals cannot trigger an episode. The reason is they get paid by a different mechanism than a DRG, the diagnosis related group. All of the inpatient episodes in BPCI are done by DRG claims billing from the hospital. That is the trigger, since critical access hospitals do not bill or get paid by DRG. They cannot initiate or trigger an episode. Any prospective payment exempt cancer hospitals cannot trigger. Inpatient psychiatric facilities. All hospitals in Maryland cannot initiate episodes. That's because Maryland had previously what was called the Maryland All-Payer System, which is now called the Maryland Total Cost of Care Program. That is a program that they have with statewide done with CMS that excludes them from other CMS initiatives like BPCI. And then there are two rural health models, the one in Pennsylvania and any one part of the Rural Community Hospital Demonstration Program. None of these can trigger episodes and therefore are excluded. The current timeline. This one is redone. This is actually borrowed from CMS, what they just put out. On April 24th of this year, a request for applications was released for the second cohort of applicants. Again, remember the first cohort started on October 1st of 2018. This is the second cohort application released on April 24th. Those applications are due on June 24th. This is where we need to record anybody that we wish to have, that to get data on, that would have the ability to work with us as a convener, needs to be on an application that is sent in on June 24th. After that time, CMS will screen the applications. They will look through that. They will weed and filter or triage some applications out. I have no doubt that ours will not be triaged out, will be perfectly fine in the June through July period. In September, and I'm hoping this is the beginning of September, we are set to receive data and preliminary target prices from CMS. The data is historic data from 2014 through 17. They'll actually be sending us 15 through 17 because they always send us the minimum necessary, which is a 3-year period of time. And they will then send us, coincidentally, but not necessarily concurrently, target prices for everyone that was on the application so that we can understand what their current pricing structure is, what they're looking at, what is that threshold of cost that they're looking to manage against. The historic data is so we can look at where they were in performance. Historically, we will probably look specifically at the latest year, 2017, to do the comparison. Also in September, we will receive what the participation agreement is going forward. That is something that we sign. The agreement that we generate for any episode initiator is based on whatever that agreement is that the CMS sends to us. By November 1st, we will need to sign and submit the participation agreement and the participant profiles and this is the time that locks people into going forward in the program. If we do not submit them on a participant profile, they will not be engaged. If they are on the participant profile, they will be engaged in BPCI Advanced beginning January 1st, 2020, with whatever episodes, clinical episodes they have chosen. There are other documents that are due in December, the start of the second cohort, January 1st of 2020. I mentioned before, you've seen the chart here in terms of what is an episode. This is DRG based, as I have said before. There are 33 inpatient clinical episodes and 4 outpatient clinical episodes. That's an addition of 4 inpatient episodes and 1 outpatient episode from where we started in October 1st of 2018. We've covered that an anchoring event, the hospital admission, is what triggers the event that is associated by a UBO4 claims invoice from the hospital that will contain certain information on it in terms of the NPI of the attending or operating physicians. That will be looked at to associate with a tax ID to determine who, if anybody, is engaged in BPCI by tax ID. They will then look at the CMS 1500 claims form from the individual participant, which is a Part B claim, match that up with the initial claim, and if they both match, then a clinical or an episode of care is initiated. And remember that the bundle includes the acute care period of time plus 90 days post-discharge. So the actual bundle period can vary anywhere from what would be 91 days to, say, 105 days, depending on the length of the acute care stay. This is an example of clinical episode selection. We put them into 3 major categories: orthopedic episodes, major medical, and cardiac episodes. There's a whole variety of these. This is not meant to be comprehensive. There are obviously more than this. Just to give you a flavor of what they are, obviously joint replacements and spine episodes are the biggest ones in orthopedics. Major medical is where you've got COPD, sepsis, stroke. They just added seizures, bariatric surgery, inflammatory bowel disease to the major medical ones. And the cardiac episodes, of course, cardiac defib, cardiac CHF or cardiac heart failure, valve replacements, arrhythmia. They just added one of the new episodes, transcatheter aortic valve replacement, or what's commonly called TAVR. That's where you can replace an aortic valve by running up through the femoral artery and doing it as not an open heart procedure. There are precedence rules that go on in BPCI, both classic and advanced. These have not changed. And this determines how a patient is attributed to a provider, because you could have instances where a physician group practice and a hospital that they do episodes at are both engaged in BPCI Advanced. Well, who is the owner of that bundle? Who gets attributed those particular clinical episodes? You also could have a case where a physician group practice that is an orthopedic practice or a cardiac practice that is independent, and another physician group practice that is a hospitalist group at the same hospital that they do episodes at. Those could both be engaged in BPCI Advanced and want to have to determine who is in charge of that particular episode. So the precedence rules dictate what that pattern is. On the left-hand side in brown, the episode initiator precedence indicates that physician group practices always take precedence over the hospitals. The hospitals are on the low end of the totem pole. Okay, so physician group practices always take precedence. Within the physician group practice side, which is on the right-hand side in green, the attending physician, as listed on a UB04 form, remember that's the claims billing form from the hospital, the attending will take precedence over the operating physician. Oftentimes, for an elective procedure, the operating physician will be the same person in the attending field. However, in emergent cases or trauma cases, there are many instances in which the attending physician will be somebody else, often an ER physician or a hospitalist. And that's where you have to start to look at what is the precedence arrangement, because if both of those entities as physician practices are engaged in BPCI Advanced, you have to know to whom that episode is going to be attributed to. And of course, in order for there to be and I'm going to use the term conflict, but an issue and a determining attribution, you have to know not only is that other practice in BPCI, but rather are they engaged in the same clinical episode, because it is by clinical episode that determines precedence. So now we want to look a little bit at the financial side of BPCI Advanced. It's really, why does anyone really get involved in this in the first place? And the rationale is that there's tremendous benefits across the board. One, we've already established in a previous slide that bundled payments are here to stay. Value-based care methodologies are here to stay. And if you choose not to get involved in bundled payments, you're really short-selling yourself for a time when this becomes a payment model that is used as fee-for-service, wanes its way out, or at least is reduced over time to perhaps only those things that one can't determine another payment model for. And so you want to be engaged in these type of programs, at least to understand how to navigate through the system and what all of these things mean, because otherwise you have to drastically change your practice patterns, and that could result in losses, because all of the value-based care programming, being value-based, will offset some sort of risk down to the providers. And so while you may be making less, you'll also be owing money back to somebody, which is a situation you don't want to get into. The other thing is, if you engage in these and you actually do well, there is a bonus that you can get in these programs. And on the left side, we talk a little bit about showing some of the principles here. So we talked about the episode scope and what it includes. The payment model stuff is based on a target price that is set. So let's just say historically, CMS has determined that a procedure is $25,000 for the acute care and the post-acute care portion of time, okay? That is your benchmark, your target. Your goal is, can you manage that patient in a fee-for-service world to manage what their utilization of services are, especially in the post-acute care period, to be more patient-centered and thereby cost less. So the example on the bottom actually uses a different starting point. It uses $30,000 as the bundle amount, broken up into, as it says here, several different parts: the acute care, the physician component, post-acute care. These are fictitious and illustrative numbers, okay? If you can manage that patient to only cost, let's say, $26,000, which is what number one is, a reduction of $4,000, CMS is going to pay that $30,000 out. $26,000 will go to the providers as their fee-for-service bill, and the other $4,000 will come back to the convener to be then transmitted to the actual providers, minus whatever fee a convener has for their services. That is what is listed as number one on the right-hand side in green: post-acute care utilization, or episode management in this case. And the dollars that come over are what is called the net payment reconciliation amount, or NPRA. It is the difference between the predicted cost based on target and the actual cost based on actual invoicing. Now, there is a second revenue possibility that does exist in BPCI, which is called internal cost savings. These are savings that can be generated within the hospital setting. Most of them are within an OR setting, but it's not exclusive for that. And it's based on devices and implants and other supplies, surgical packs, preference cards, and whatnot. It is a second revenue stream because it's generated from the hospital. It does not influence what comes from Medicare. The hospital is paid a DRG payment as a set payment. If you can reduce the costs in the hospital while they receive the same dollars from CMS, you can share in the savings as long as that is auditable and identifiable in terms of actual cost. It can't be paper cost. It has to be real cost. And what number 2 illustrates is various aspects of internal cost savings and an additional savings of, in this case, $2,000 that could be generated there. Ultimately, that gives you a $6,000 savings that could be shared among the people in the practice and the physicians, as opposed to not having any savings at all and having that episode cost $30,000 or more. There are several regulators of success here, or the mechanics that are involved in sharing of gains. And if you look at the 3 wheels, the first one indicates financial risk. We've talked about this. There is downside risk that is part of this. If you're not good at this program, or for some reason things go awry, there is dollars owed back. That is a risk. The certified CEHRT means that you have to use a certified health recording mechanism or EHR, which is an electronic health record system. That is important. There are percentages that go along with this. This is not 100% compliance with this. It's about 75% of the providers within a particular entity. As long as you fulfill that, which virtually all the providers that we're engaged with do, we're absolutely fine. And then there's a quality component in here. Quality has to be maintained. There are quality measures for any distribution of funds. So while you may incur savings because you can manage patients better than what was done historically, and for the most part, if nobody was engaged in BPCI Classic, they didn't manage anything at all. So therefore, generally, things can be done better. In order to engage in any sharing of those savings, quality measures have to be met. What's listed down at the bottom is the ability to do gain sharing, as well as the ability to do care redesign efforts, will be coming up in a couple of slides here, are based on waivers that are applied to the fraud and abuse laws. And we're going to cover a couple of those as well. The program has several mandatory measures. I know that this slide is difficult to read. There are 7 measures that exist right now. Down at the bottom, there are measures that may be incorporated in 2020. We don't know that at this point in time. The mandatory measures are what makes this program an advanced APM. Without the mandatory measures, this would never qualify as an advanced APM and would never have the ability to give yet a third potential revenue uptick, which is that MIPS MACRA qualified provider QP status that we talked about. There is an upcoming webinar that I believe is in about 2 weeks that is the next iteration of this series that will talk about MIPS and MACRA and QP determination and how that, the impact of that to any provider and how this program records those measures. So the mandatory measures here do have an influence on performance. So as I said, that the advanced APM, there are quality measures that are a part of MIPS. MIPS is the merit-based incentive payment system. BPCI Advanced will calculate from the measures that are mandatory a quality score for each one of those measures at the clinical episode level. They will then aggregate individual scores and will weight those based on volume and scale those across all the clinical episodes for any given episode initiator. And so the mechanics of doing that are extremely complicated and frankly not worthy of going through unless you like high-level mathematics. The score will be different for any given type of provider episode initiator based on that volume and the patients that they serve and the locations in which they do their episodes. What CMS will do is apply that composite quality score to what's listed in the green boxes on the right. Again, each is weighted and scaled. They will create a composite score, or a CQS, which will be measured across for outcomes for each EI. And the CQS can influence your total reconciliation. And it can do so by up to 10% of the amount in reconciliation. Reconciliation is the point in time in which if you have savings, they'll be distributed, and if you have amounts owed, that will be a repayment. And by up to 10%, I mean based on the score, the composite score that you get. Let's say a particular episode initiator was able to save $1 million in a performance period, and a performance period is a 6-month period of time. Generally, the first 6 months of the year is one performance period, the second 6 months of the year is the next performance period. If they saved $1 million in a performance period, the composite quality score influence could mean that you could get a haircut of that of 10% or $100,000. So while you saved $1 million, you're only actually going to receive $900,000 of that. Conversely, however, if you did really well, and that's if you did terrible, right, and you didn't achieve any measure that allowed you to retain. If you did very well on your composite quality score and you saved $1 million, you would get the full $1 million. If, however, you had net losses, if you did really well in the program, your net losses would be reduced by 10%. Whereas if you did not do well in the mandatory measures and had a terrible quality score, you would owe the full amount back of whatever that loss was. I added the part to the left here on the qualified participant, or QP. This deals with the MIPS MACRA components as part of the MACRA legislation. This is that third entity in which, if one qualifies as a QP, or qualified participant, based on thresholds of patient volume or patient payments that are based on Medicare volume and Medicare payments relative to the total, you may, if you receive QP determination, you may be eligible for a 5% incentive payment based on the fee schedule. That is kind of the hidden gem in here. It is difficult to reach. We don't stress this much because we know for any given provider, this is not something that may be likely, but we don't know until time goes on. How do funds flow? NPRA comes from Medicare. The dollars flow from CMS to the convener, that would be us. We then process that. We have a fee of whatever it is that we take out. The remainder of the dollars go into a savings pool. This is a fictitious pool. You can think of it like a bank account. It's actually a ledger account. That gets paid out to the episode initiator, which could be a acute care hospital, if that happens to be the episode initiator, or a physician group practice. And then they will have a distribution, depending on what their choices are, to what they're called gain sharers here, which is actually the physicians who perform the episodes. Okay. If you did not perform an episode or have any impact on an episode, you don't have any share in gain sharing. That is for those that are actually participants. Internal cost savings is listed on the bottom. That's ICS. There's an initial relationship between the convener, the hospital, and the episode initiator. They all get together, work on what can generate internal cost savings, those dollars that can be generated based on whatever that contractual relationship are funneled to the convener, to the savings pool. That is not something that we share in any of that dollar value. That goes into the savings pool for distribution out to the episode initiator. So how does all of this work? How do you generate funds? How do you become successful in this program? It is really through care redesign, case management services. These are the things that deliver results. Fusion 5 has 5 core services at its heart, aimed at maximizing cost reductions, and they need to be flexible. They need to fit unique customer needs, because not every customer is the same, not every physician practice is the same, not every orthopedic practice is the same, and even within an orthopedic practice, each physician cannot be the same, and that's usually the likelihood. So there are several properties that are required for care redesign. What our job is here at Fusion 5 and how we gain success with our clients is to integrate care redesign and care coordination together so that we can maximize the efficiency of patient care and minimize the overutilization and waste of services. This requires several attributes. A platform to do this, we have a proprietary case management platform called eFusion. That works for elective and emergent cases, as well as any other type of episodes that are even not Medicare. It includes risk assessments, so you can have a predictive model in terms of identifying high-risk versus low-risk patients because they will adjust touch points. It is evidence-based. Fusion 5 has the expertise in order to support case management workflow and transition of care planning. And then we have ongoing training and education, very much like this webinar is. Okay? The key element to care redesign is that care coordination is at the center. It involves a whole variety of attributes, but care redesign is the focal point. And during that process, you want to really focus on the patient and their unique needs and how they fit into this continuum. This includes biopsychosocial assessment, comorbid conditions, looking at a holistic approach for taking that patient and understanding the patient as a whole and what their needs are and how to best serve that patient for what needs to get done. Sometimes it's managing that patient by not initiating an episode right when you think you are. But if they have issues that need to be addressed, addressing those issues first so that when you're actually, they're more well prepared to do the procedure that is necessary, they will then have a better outcome and generally also at a lower cost. Care coordination has a rather unique workflow. It is designed here. You really want to determine the eligibility, that is that optimization portion up front. Look at the biopsychosocial assessments, develop a care plan. At any point you can go back as things change and think about re-entering an optimization pathway to go back and then redo some of these steps. Really work with patient education and their family caregiver members, and then work on those transitions of care and the care necessary across all phases of care. The care redesign focus is attributable to any one of the areas of episodes, whether they be orthopedic or the major medical episodes or the cardiac episodes. You really want to look at identification and management of biopsychosocial concerns as those listed here, coordinate across them, understand chronic and comorbid conditions and the social influence that goes on, those behavioral health needs that actually do in fact drive up costs and are often the most overlooked. And then management of the post-acute care period. It is extremely important, and one of the things Fusion 5 excels at is understanding and building post-acute care provider networks, preferred networks, and managing those networks so that you have buy-in from what those are. They're actually performing the same functions for the same reasons to maximize patient care. In order to do all of this, legal components are an important part. There are waivers to the fraud and abuse laws, which is basically STARK, or the physician self-referral law, civil monetary penalties, and the federal anti-kickback statute. There are also discrete program waivers in here that allow all the parts to go on. And so the incentive and gain share payment waiver that comes from the savings pool generation. There are beneficiary incentive waivers. These are things that you could not do for a beneficiary, and we're going to describe them in the very next slide, that would otherwise have been illegal, but they're permitted in this because of a waiver from the OIG. And there are waivers to the 3-day SNF rule, so you don't have to have a 3-day qualifying event in the hospital to go to a SNF, although I would probably say that if a patient does need to go to a SNF, they may be better off in the hospital for 3 days, but that depends on the potential for complications. A telehealth waiver, because the telehealth regulations are a little stringent right now and they need to be relaxed, and post-discharge home visit waivers that allow visits at the home by a clinical staff as long as they're supervised by a physician. There are obviously beneficiary protections in here in which the beneficiary needs to know that they're in the program. They don't have the ability to opt out, but they do have choice, which is what Medicare always has for all of its beneficiaries. Incentive waivers are designed to allow and expand the boundaries of what any provider can do. And that is, these are permitted now by OIG with the goal of providing temporary low-cost service in lieu of a high-cost service. So why would a patient need to go to a SNF if their barrier to downstream care was that they didn't have transportation from home to go to outpatient services? So what you can do is provide that transportation so they can get to outpatient services and bypass the need of a skilled nursing facility because you can provide them. Or you could provide an in-home aid to cover some of the territory that this patient may not be able to do, as opposed to them going to a SNF. That then provides value in terms of maximizing care delivery. And several examples of these are, as I said, transportation. We could do assisted living care, short-term care home aids, things as even as simple as pet boarding. If you believe that their pet is a fall risk, you can eliminate the fall risk for, say, a week, so that the patient is much more stable after that period of time. The pet can go back home, and now you've avoided what could be a potential high-cost complication during that critical period of time when the patient first goes home. That actually concludes the presentation that I had here. The next steps here are really upcoming webinars. I had mentioned before that the next one will be on MIPS, MACRA, and that determination of QP and what that impact is, how BPCI Advanced plays a role as an advanced payment model. Two other things that I wanted to bring up: a reminder that the application deadline that we need to get people in the application is June 24th. Only ones that are in our application on June 24th can be episode initiators with us at Fusion 5. And going forward, what we're looking to do is, after that application, obtain that BPCI baseline data and the target prices from CMS, generate opportunity analysis and review those with those potential clients to determine what the best course of action is for them to move forward and engage in BPCI. I can now open this up to any questions that we may have.
Attendees, your lines are now unmuted if you have any questions for the speaker.
Well, I either was crystal clear or I put everybody to sleep.
If you have any questions after the webinar that you weren't able to ask during, please feel free to email us at questions@fusion5.us. And again, we will be sending out additional information on our forthcoming series of webinars. We have 3 left. The next one is on MIPS and MACRA, and that's on May 22nd.
Thank you very much. So long now.